here's our case 5. Oh, 4, sorry. That should actually read numbness, sorry. I typed there, mistyped. So it's a 75-year-old man with numbness.
Does he have weakness?
No, he doesn't. Just ignore that.
Where is his numbness?
His numbness is on the left side.
The whole left side?
The whole left side.
Face and arm and leg.
Face and arm and leg, correct.
How quickly?
It came on very suddenly.
How long has he had this for?
It started yesterday.
What was he doing when it started?
He was having his breakfast.
Any speech problems?
No,
Vision and hearing problems.
fine.
Has he had this before?
He's never had this before.
Does he drink alcohol?
He drinks 1 glass of red wine at night. Good boy. Yes, you told him to.
Is he a smoker?
No, he doesn't smoke.
Is he on any medication for blood pressure?
He's taking medications for blood pressure, yes.
Any other medications that he's taking?
He's taking metformin.
And the sugar and blood pressure well controlled?
He struggles a little bit with sugar control, and his blood pressure today is 159/96, which is a wee bit higher than usual, but you've been working with him for a while on this.
Any difficulty swallowing?
No difficulty swallowing.
Who's at home with him?
His wife. And he's starting to improve slightly. So this may be of interest to you. So he didn't think it was a big deal. It came on, he couldn't feel anything for a while, started to improve, hasn't come right. And his wife dragged him in to see you today, even though he knows nothing really is wrong with him.
Where did he sleep last night?
In his bed.
And it's in his face as well?
It's in his face as well,
On the same side?
on the same side.
Any balance problems?
He's struggling a little bit with walking.
Meaning?
Well, he's unsteady a little bit when he walks. That's what he tells you. What would you like to do next?
Oh, is there a history of trauma?
No history of trauma. So
Otherwise, well,
no fevers, otherwise well. What are you thinking at this point?
brainstem.
Very good. We have a localization. So you're thinking brainstem. What makes you think brainstem?
It's a lateral.
Okay,
Yeah.
so let's.
The face and the rest of it is on the same side.
Okay. So let's start from the periphery. Could it be a peripheral nerve problem? Oh, sorry. Could it be a muscle problem?
No.
No. Why not?
It's not a muscle.
Because it's sensory. Could it be a neuromuscular junction problem?
No, same reason.
Same reason. It doesn't affect the sensory part of the body at all. How about a peripheral nerve problem?
No.
Actually, it could be. It is neuroanatomically possible that it's a nerve problem. It's just highly unlikely because you could have a multiple mononeuritis multiplex affecting the face, the arm, and the leg. It's very unlikely, but it's not as impossible as a neuromuscular junction problem would be, which is completely impossible. So it's not likely because of the distribution. So you're getting that right. It's just not absolute. And sometimes you do have people presenting with sensory symptoms that aren't in the typical pattern. But you're right, it's not likely. What about a brachial plexus problem or a lumbar plexus problem? Absolutely cannot be a plexus problem. Why not?
Because it involves the face.
Because it involves the face. What about a spinal cord problem?
No.
Okay, so that's where it gets a little bit trickier. So the trigeminal nerve nucleus, there's a bit of fiber that goes quite deep in the cervical cord, and you can get a bit of numbness in the face from a high spinal cord lesion, but you can check that on examination, and if he has numbness in the forehead, then you know it's not a spinal cord problem. Certainly much less likely, and it's not what you're thinking, but it isn't 100% excluded. So we've already said it could be a brainstem problem. Can it be a brain problem? A supratentorial problem?
Yes.
Okay, we have some divergent views on this. So who says it couldn't be in the brain itself? Okay, so what's your rationale for that?
It would be ipsilateral and then contralateral lower down.
If it were in the brain. Okay, what do other people think?
I mean, when you said supratentorial, I mean functional way.
Oh, I see. Yeah, that is another way of saying that. So it could be functional as well. But so, does anyone think it could be in the brain, above this tentorium, above the brain stem? Okay, so we're going to get a scan, and here's the problem. This is the infarct, so you all thought it was a stroke because it came on suddenly, but it localizes to the brain, not the brain stem. It's in the thalamus. Remember, the thalamus is the great sensory relay station, and typically, when you look at the textbook, it's the brain stem lesions that have crossed findings, where you have one side of the face and the other side of the body, because at the level of the brainstem, the pons in particular, when you're talking about sensory problems, because cranial nerve nucleus 5 lives in the pons, it becomes a lower motor neuron problem. Think fibers cross over at that stage. So you can have an ipsilateral facial numbness and a contralateral body numbness. That's what you were thinking of, I believe. But if you move above the brainstem, everything will be on the same side. So you've got it opposite. So this patient, and maybe I was unclear, and that may be my fault, but this patient had left-sided numbness in the face, arm, and leg, all on the same side. Did I communicate that? Yeah. So no cross signs. So you think brainstem if something's on one side on the face and the other side on the body. You think higher up if it's all on the same side. In reality, most brain lesions, whether they're in the brainstem or higher up, cause symptom all on the same side.
And that's because of the concession, is it, in the medulla?
That's correct. Well, it's when you're involving cranial nerves, it gets a little bit more complicated than that, because the decussations refer to limb sensation, and yeah, so that's lower down, correct. And the cranial nerves come off above that. So there is a synapse in the brainstem between the upper motor neuron and the lower motor neuron, or the other way around, the sensory nerve and the extension up into the thalamus that occurs at the level of the brainstem. So that's why you get ipsilateral on this side.
Can you say what you just said about the sides again?
Yeah.
Okay.
Please.
All right. So pretty much, I'll say it slightly differently.
Yeah.
So in general, when you have a brain lesion, it will cause contralateral symptomatology,
Yes.
all on the same side of the body. So if you have a left brain lesion, you generally have right-sided symptoms, face, arm, and leg. Okay, as a general rule. As you move further down, that becomes less perfect. Okay? As you move into the brainstem, you can start getting crossed presentations, where you have on one side facial symptoms, on the other side body symptoms.
And which side's the lesion?
So if the lesion is on the right side of the brainstem, you'll get right facial numbness and left body numbness, because those fibers haven't crossed yet. The body fibers don't cross till down, for a bit further down in the medulla. Should I say one more time, or?
Yes, please.
Okay, so so if you have a brain problem, you have symptoms on one side of the body, as a general rule, if you have a lesion on one side of the brain, as a general rule, the symptoms will be on the other side of the body. So this person has a right thalamic stroke and has left hemibody numbness. If they had a left caudate stroke, they'd have right hemibody weakness, because caudate is a basal ganglia that modulates motor function. As you move, so anything above the tentorium, everything is crossed on the other side. As you move further down to the brainstem, you will start getting some things ipsilateral to where the lesion is. So if you have this lesion in the pons on the right, you may get right facial numbness and left hemibody numbness involving the arm and the leg. This is confusing, so don't,
Where is the tentorium?
Where?
Yeah, what is the
The
tentorium?
tentorium separates the brainstem and the cerebellum from the cortex and above.
Okay, thank you.
You can see it, actually. You can't see it on that, but it's a meninges and bone. There's a bit of bone in there as well. So, yes?
Yes.
Moving on? Okay. So this is a classic lacunar stroke. So lacunar strokes, you've heard of those? So there's two general kinds of strokes. There are the lacunar strokes, which are the small ones, and they're called lacunes. Lacune, apparently, I don't speak much French, but it's the French word for lake. And somebody thought that looks like a lake. Yeah. So the other kinds of strokes, and I don't have pictures of it, but if you had a big wedge taken out over here, that would be consistent with a middle cerebral artery stroke, which is not a lacunar stroke, it's a large vessel stroke. So there's small vessel disease and large vessel disease. And the small vessel disease is called small strokes, and the large vessel disease is called large strokes. And proportionally, they cause different symptomatology. So the lacunar strokes tend to cause very small strokes, and they tend to occur in the deep structures. And the reason why they occur in the deep structures is because you have lots of small blood vessels there, and they are under significant pressure. And blood pressure is the biggest risk for having lacunar infarcts. Blood pressure also causes other atherosclerosis, but it's a particular strong risk factor of high uncontrolled blood pressure and diabetes damage the small little blood vessel in the depths of the brain and cause these lacunar infarcts. And they tend to cause unilateral numbness, unilateral weakness, some numbness, some weakness combined. They can cause some ataxia. They can cause some dysarthria. What they don't cause, they generally do not cause language dysfunction. So they do not cause dysphasia. They do not cause visual field deficits. So occipital lobe tends to be a large vessel stroke.
Could you do neglect?
Neglect also they do not cause. So neglect is a cortical sign. So these strokes do not affect the cortex. They affect the deep structures that I talked in the morning about, the thalamus, the basal ganglia, the brainstem.
Does the anticoagulation treatment work as well for the deeper structures as it does for the outside of the brain?
That's a very good question. I'll talk a little bit about treatment, but not that much, so I'll answer that question now. So we do not use any anticoagulation for lacunar infarcts. There's no evidence that anticoagulation helps in situ small vessel disease. And the other problem with them is they're at high risk for bleeds. So those locations are the same locations that people have hypertensive hemorrhages. So they'll get them in the thalamus, they'll get them in the putamen, in the basal, in the caudate, and the pons, is where people get these hypertensive bleeds. So we don't. There's no evidence to suggest that anticoagulation helps with small vessel in situ strokes where the disease happens right at that vessel. The blockage is right there. It's not an embolic event. Now, once in a blue moon, you'll get something that looks like that is actually an embolic event from the heart or from the carotid. And if it's from the heart, we will use anticoagulation. But don't worry about that too much. The message is really lacunar infarcts are small vessel disease, and small vessel disease we do not treat with anticoagulation.
What about aspirin?
Aspirin we do use, yes. Antiplatelets is what you want to use in these people. So TIA and stroke. So you know this. So it's a vascular event, sudden onset of a focal neurologic sign. Loss of consciousness, we don't consider a focal neurologic sign. Loss of consciousness is a sign of global cerebral hypoperfusion, which is why you get it when you have vasovagal syncope or cardiac syncope. Now, we talked earlier about epilepsy, which is a little bit different, but we won't talk about that now. But when you're talking vascular global cerebral hypoperfusion, so in order for a stroke to cause loss of consciousness, you have to have both hemispheres involved. That's really difficult with a stroke. And it's usually systemic hypotension. You can take out the reticular activating system in the brainstem, and if you ever have anyone with loss of consciousness presenting with a stroke, that's almost always where it occurs, but it's so exceedingly rare that I would just remove loss of consciousness off your signs that you think of as presentation of stroke. Just don't connect those, because you'll cause more problems with that connection than you'll help anybody, and they go to the wrong clinic. They don't need to be in TIA clinic, they need to see a cardiologist or get an ECG, those kinds of things. So loss of consciousness is not a sign of stroke. Confusion, as in delirium, also is not a common presentation of stroke. The difficulty is if you're really dysphasic and have a receptive aphasia and cannot understand what anyone's saying around you, it can look like you're confused or delirious. But the difference is that these people are wide awake, sitting there, bright-eyed and bushy-tailed, just don't understand what's going on. They're not delirious in the way that somebody is delirious who has a pneumonia, an elderly lady who's septic. They're not in and out, fluctuating level of consciousness. So usually when we're talking about strokes or TIAs, we're talking about unilateral weakness, numbness, vision loss, sometimes vertigo, which is borderline, usually it's not a stroke, but it can be, or double vision, that sort of thing. Now, TIAs usually resolve really rapidly, within an hour, and if they last longer than that, chances are if you did an MRI scan, you'd find an actual lesion on the scan. And one of the key messages is that really all strokes and TIAs require urgent assessment to maximize good outcome. That doesn't necessarily mean that all patients need to see a specialist, but they do need to see somebody who can start them on medications and assess them for risk and etiology and rule out things like bleeds. So I'll talk a bit more about that. So these patients need to be triaged either to inpatient assessment, not so much, well, partly, and there's different views on this, but some people would say they need to see a specialist ASAP within 6 hours, so that we can do a CT scan, get a carotid ultrasound, get an ECG, and then start medications. I believe that I'm not the important bit in that equation, but the important bit is actually the CT scan, and that somebody needs to start them on medicines. I don't think really that it's rocket science to do this, and I'll tell you more about that in a minute. But having said that, TIA is a challenging diagnosis, and it can be very confusing. So and you don't see many of them, do you? The average GP sees a couple a year, something like that. So it's not a common presentation for you. We see about 5 a day. So obviously, with that experience, you get a bit more comfortable with making that diagnosis. And then also, even if you only have a mild stroke, so the patient doesn't have a lot of disability, don't underestimate the disability they have that you haven't recognized yet. So there's a lot of cognitive disability. They may not be delirious, but they may have some cognitive problems like dyspraxia or other memory problems from the stroke that aren't immediately apparent. We tend to focus on weakness and numbness because that's easily picked up. But they may have difficulty balancing their checkbooks. They may have difficulty navigating through the house and cooking themselves tea. And we recommend that anyone who has ongoing complaints, if they say, I'm not right, that they get actually admitted so that they can get urgent OT assessments and physiotherapy assessments to get in there quickly. If you refer them to outpatient occupational and physiotherapy, it might take 2-3 weeks, and that's kind of lucky. You know, if you just sort of go into the routine queue, you might miss out on early rehabilitation and input. You've exposed them to injury risk, and you're missing out on the window of maximal neuroplasticity, where rehabilitation is really effective. So we don't have a very good way of addressing that in most DHBs in New Zealand, and generally recommend that if you have any disability, just have them go to the hospital. But I'll talk a little bit more about triage. So with TIA patients, the New Zealand TIA guidelines separate people into high and low risk patients, and most of you will be aware of the ABCD2 score. So the high risk patients are those who have a quote unquote active TIA, so that's somebody who has still some kind of symptomatology. Generally some weakness or numbness. So this guy still has a little bit of numbness, so that's actually a stroke until proven otherwise. It's not really a TIA until it's resolved and 24 hours are up. So if they're presenting and still have symptoms, that's considered high risk. If their ABCD2 score is equal to or greater than 4, and ABCD2 is A for age, over 60 scores 1 point, B for blood pressure, over 140 over 90, either number greater than 140 over 90 scores a point. Clinical is 1 point for speech deficit without weakness, and that could be either dysarthria or dysphasia, and 2 points if they have weakness anywhere on one side of the body. Duration, 0 points if it's less than 10 minutes, 1 point if it's 10 minutes to 59 minutes, 2 points if it's over an hour. This is duration of symptoms. And the second D is for diabetes. So they score a point for diabetes. So this chap, our guy, say his symptoms had resolved. He was over 60. He was 75 years old. His blood pressure was over 140 over 90. His symptoms lasted more than an hour. So he had 2 points for that. And he has diabetes. So he's got 5. And he didn't have weakness, but he had a speech deficit. So he has actually a score of 6. So this would be a high-risk patient, even if symptoms had all resolved, indicating that he's at very high risk of having another event within the next 48 hours. And those people we want to manage urgently. Even if your score is low and you have symptom resolution, if you've had more than 1 over the last 7 days, that also increases your risk of having a further event and makes you high risk. And then if you have atrial fibrillation, why would that indicate high risk? So you have active atrial fibrillation, so you might have a clot and you might have another embolus. So that's one of the reasons. The other reason is because what do you want to do with this person? If they have atrial fibrillation and just had a TIA. You want to get them anticoagulated, and you cannot do that until you've had the CT scan. So that is the one patient population you absolutely need to get a CT scan on before you anticoagulate them. And you really ought to hold the anticoagulation that they're on, if they're already on it, until you've had the CT scan before you continue it. That doesn't mean you need to reverse them there in your office, but what it indicates is these people need to have pretty urgent assessment with investigations that is really only practical if you send them to hospital. So that's why these people should go to hospital. The other people who are not an AF or aren't on anticoagulation, you're putting them on an antiplatelet, you can do that without having the CT in hand. It's a bit of a controversial topic, but I believe the risk is really low that it's unlikely that they've had a bleed, because we're talking TIA symptoms now, people with TIAs whose symptoms have resolved. So it's unlikely it's a bleed in the first place, not completely impossible, but pretty unlikely, and even aspirin in somebody who's had a bleed is not the end of the world. Anticoagulation is the end of the world for that patient. You will kill them. But aspirin is a very low risk of extending a bleed, and we give aspirin to people who have cerebral thrombosis with bleeding into it. We give, if they have had thrombolysis and had a little bit of bleeding related to that, we give them aspirin. So the risk isn't nearly as high.
Would you give them a starting dose in that case? Would you give them a starting dose? Or?
If they have a completed TIA and are not symptomatic anymore, I would give them a loading dose. Is that what you're asking? Yeah. Okay. So depending on where you're at in the country, and we have got people from all over the country, and I happen to know all your TIA pathways because one of my jobs is to know these things and work with the ministry. And so the different people, so in Auckland, for example, if you work with Auckland City Hospital, your pathway, whether you know it or not, is for you to send all TIA patients straight to the hospital to be assessed by a specialist. I'm not sure, I think they do it in the MAPU setting rather than a TIA clinic. In Wellington, they do a TIA clinic. You can pick up the phone, call us, and we get them in the next day. In a lot of other places, what you do is you send them to ED for them to be admitted to the stroke team. So there's different methods, but the key is it doesn't so much matter where they go. The key is that if they're high risk, they need to be in a place where they can get imaging and care within 24 hours of their symptom. If they're low risk, you have a little bit more time. You have about a week to get all of these things done, but they're all fairly urgent. So these are then the low-risk patients, which are just the low ABCD2 scores of people who had the symptoms over a week ago, which the high-risk period is over. And these can be managed in the TIA clinic even a few days out. So if you even see them on Friday, that's okay for them to come on a Monday or Tuesday. Or you can manage them in the community yourself if you can access these investigations. So what you do, you get some labs. Labs are relatively unimportant in TIA stroke. I mean, we do check glucose and lipids and those kinds of things, but we don't do big metabolic screens. We do an ECG. Everyone needs an ECG to do what? To look for AF. We get the CT and an ultrasound if the symptoms are anterior circulation and the patient is a surgical candidate. So we have limitation on access to investigation, so we generally do not get an ultrasound unless we actually will do something with that result. And if they have diplopia and a clear brainstem stroke, and then you get an ultrasound and they have a 55% stenosis, then you're scratching your head because really it's an asymptomatic carotid stenosis. They've just had a vascular event, and then you're just causing some angst amongst yourself and the patient. So I'm a big believer in ordering tests when it actually will change my management, because I found so many things on tests that I was looking for, and then I spent more time explaining these things. But it's a bit beyond the scope of today. I could talk about stroke for days, so I'll stop.
What about an echocardiogram?
Yeah, so that's a very good question. So I deliberately didn't mention that. Echocardiogram is another one of those tests that has a pretty low yield in stroke and TIA. Now, it's a great test when you have a cardiac problem. AF, you can see signs for AF on an echocardiogram, but the ECG is the better test for that. We do occasionally do Holter monitors or reveal devices to look for ongoing paroxysmal AF. It becomes at some point the question, if you capture one run of 5-second AF 3 months after they had the event, how relevant that is to that event. So there's still a lot of debate over what to actually do for AF. So I usually do serial ECGs. So if they get admitted to the stroke unit, we do 3 ECGs, and I don't get an echo. There's no prediction. If you look at studies, they've looked at echo utility in stroke and predicting recurrence, and it's not very good. The one thing you can find on an echo that you cannot find any other way, that generally isn't explored in other ways in New Zealand, is in the PFO, so patent foramen ovale. So if you have a young patient with an unexplained stroke, and you think they may have a paradoxical embolus, so like a DVT that went up to the heart and then went over from the right to the left side. So you have a bit of a shunt, intracardiac shunt, because the PFO that was there for good reasons when you were a baby didn't close all the way. The partial atrial septal defect. You have a bit of a clot going from the right to the left and then flicks up to the brain, and you can get an embolic stroke. So those are really good to test for with a toe, really, transesophageal echo. And then you run into the whole controversy over what you should do with a PFO when you find one. So I would suggest that for a GP, there probably isn't a role in ordering an echo purely for the workup of TIA or stroke. So I would just not consider that routine.
I mean, how else would you find the neural thrombus if it's an intermittent? You need an echo.
Yeah, so how often have you found a mural thrombus in the setting of acute stroke or TIA? So I have never found a mural thrombus that I didn't know might be there because they also had AF. So, yes, you have people with valves that have vegetations, but then they have a valve, so you already kind of know that they have at risk of that. So it's just not, and then the chance that it's still there by the time you finally get the echo. So yes, you could find additional information, but the yield is just so low that it doesn't warrant, in my mind, getting the test when there are so many other better indications for an echo, and you have then people waiting for 3 months getting an echo they needed tomorrow because instead they did somebody with a stroke who didn't really benefit that much. So it's a resource issue. In an ideal world, I mean, when I worked in the States, so this is about 10, 15 years ago, we would get it on everybody. They would come in, they get an ultrasound, they get an echo, they get the MRI scan, get it all done, and it never changed what I actually did. But the patient felt like they got great service. So then as far as medications, there's a bit of debate over what the best antiplatelet is. There's a school of thought that thinks aspirin is the way to go for everyone who's had a stroke or TIA other than the cardioembolic strokes, because it has a good efficacy, it's well tolerated, it's very cheap, it's once a day. People don't mind taking it, it's a household name, patients are comfortable with it, good compliance. If you look at guidelines, generally most guidelines say either clopidogrel or aspirin plus dipyridamol, because there's slightly better efficacy with either clopidogrel or the combination of aspirin plus dipyridamol. So those people would say, well, why not give people the best we have? The others would say, well, if they then take neither, then that's not particularly helpful. So my view is that it's patient dependent. So if you have a young person who's motivated to do whatever they want, then I would probably put them on clopidogrel. But if it's an elderly patient who has lots of other drugs or somebody who isn't very keen on taking medications, I'd be very comfortable maintaining them on aspirin. At Wellington Hospital, the lead stroke physician there just puts everyone on aspirin, unless there's a really good reason otherwise. Now it's a little bit different in the acute phase, and I'll talk about that. There's some new data that's come out recently about that, but that's for long-term treatment. It probably doesn't matter that much. So what I generally do is I put them on aspirin, and then if they have another event, I'll reassess that, and I might switch them to clopidogrel or add dipyridamol. Everyone really should be on a statin, and I had a little chat with somebody earlier. Of course, they cause side effects. And what's the dose? So if you look at the data, 80 milligrams of atorvastatin is a pretty hefty dose, and a 90-year-old lady will have difficulty tolerating that. That's best evidence. Again, it's a little bit like going with clopidogrel. I usually start lower and tailor to the patient's risk profile. There is very good evidence that putting people on a statin after a cerebrovascular event will reduce their risk of recurrence, whether they have high cholesterol or not. But the number needed to treat is a lot lower than antihypertensive or antiplatelets, so I focus on those and am most willing to compromise on the statin. But if you want to do the best you can for your patient, you put them on antiplatelets, a statin, and an antihypertensive. And even with the antihypertensive, they have a blood pressure of 130/85. There is evidence that adding a low-dose antihypertensive will reduce their risk of stroke, even if they're what we consider normotensive, as long as we don't risk their symptomatic hypotension.
So you did say you would put a 90-year-old on a statin?
No, I didn't say that.
So
I said I would tailor it to the patient.
Yep.
Now, I have some 90-year-old patients who look more like they're 70, and they have a lot of vigor and want to keep going, and I probably would trial them on a low-dose statin, maybe 10 milligrams of Simva, and see how they go. I'd give them the option. So I think that it's important that we offer all patients what is available, but then tailor the discussion about risks and benefits around their particular profile. So, there's different philosophies around that, and I've had lots of geriatrician colleagues who say we shouldn't use all these drugs in older people, but then I have geriatrician colleagues who say we shouldn't discriminate on the basis of age. So, what would you do?
I would tailor it to the patient.
Yeah. So that's where I think, that's why we're doctors and we can't just follow a protocol. I mean, that's dependent on the patient. So if you do and then warfarin or dabigatran, if you instead of antiplatelets if you're in atrial fibrillation. And that's pretty much the main indication for anticoagulation. Somebody asked earlier if the evidence is as good for small vessel disease. It is not, and it's only cardioembolic strokes we treat with anticoagulation. Everything else, the more time goes by, the more we realize is causing more harm than good. We used to put big vessel disease on anticoagulation. We no longer do that. We used to put all people with dissection on anticoagulation. We no longer do that. We used to put all PFOs on anticoagulation. We no longer do that. So as time goes on, we're just realizing these antiplatelets are pretty darn good at what they're supposed to do, and it's really just the cardioembolic stroke. So if you do all that, if you look at some data, it would suggest that doing those things decreases the 90-day stroke risk from up to 18% to just 1 to 2%. Now this is best case scenario. These are really high risk patients, but you can lower their risk to that. So this is why it's important to get all of that done quickly. And then just to, this only works if you do it quickly. So if you see them and then a week later we see them, it's sort of the horse is out of the barn, so to speak. So we really, I want you guys to start doing these things, and we have some ways to help you with that. Not to forget that lifestyle advice, especially smoking cessation, much more, getting somebody to stop smoking much more effective than putting them on a statin. I cannot overemphasize that. Now I know it's a lot harder to get somebody to stop smoking, but I thought it's important to mention that. And then driving advice. After a TIA or stroke, minimum step down is 1 month. So there's some new things in the stroke world. Intra-arterial clot retrieval, have you heard of this? So there were 3 trials in the last 12 months, really more the last 6 months, that have shown dramatic benefit. So 71% of people treated with clot retrieval versus intravenous thrombolysis were independent at 90 days versus 40%. Another study had 53 versus 90%. Mortality halved compared to IV thrombolysis. So this is where you go in with a catheter, you go up into the middle cerebral artery, inject a little bit of TPA, and have a little device, like a little umbrella thing that catches the clot and pull it back out. That's called clot retrieval. There's other devices that are more like a corkscrew that go through the clot and then pull down, just like you'd open a bottle of wine, but those have a bit fallen out of fashion, so it's this sort of umbrella device that is mostly used. Now, I don't use them, but that's my understanding. So that's really difficult to do in small centers. So it's only going to be, currently it's only done really in Auckland, to a lesser extent Christchurch, Hamilton. We just did somebody here Monday. So it's just really new. It's not new to the interventional radiologist. It's quite similar to other things they do with coiling of aneurysms. So the technique for them isn't that different, but it's the whole protocol around it that is still a bit challenging, and we're just developing on the national level systems for destination protocols. How do we get people to larger centers? A very small percent of people qualify for this. So it's heralded as sort of the greatest thing that's happened in stroke in the last 15 years, but it only will ever benefit about 3% of people with stroke. So putting that into perspective, it's not, just not a lot of exciting things happen in stroke, I think, is the bottom line.
How quickly can that be done?
6 hours.
6 hours.
And the sooner the better. And so just a reminder, if you see somebody with a stroke, acute symptoms, just stop doing what you're doing, call an ambulance and get them to us. IV thrombolysis we can give up to 4.5 hours. The evidence is much better for up to 3 hours. So we want to ideally treat them as fast as possible. And we know that the longer you wait, the less likely the chance of recovery. It's not a cut off right at 3 hours, it's a linear progression. So the longer you wait, the greater the risk of bleeding and the lesser the chance of recovery.
Excuse me, can I just ask, how do you access your CT scan within 3 hours? Like you just push somebody else out so that you can get it?
Pretty much. CTs don't take very long, so even if somebody's in the scanner, it's not that hard to, it'll only take 5 minutes for them to finish and get the next person in. What we do now is we do pre-hospital notification, so the ambulance rings ED saying we have a stroke that's fast positive, so they use the face, arm, and speech stroke foundation screen. Then the ED triage nurse rings us. We have a code pager, just like if somebody has a rest in the hospital, and they tell us when the time is that the patient arrives. So we arrange for the CT before they even get here, and we meet them at the door and we take them to CT. So we can achieve door-to-needle times of 20 minutes. Out of hours, it's more challenging because we then drive in from home, and it's just not as well organized after hours. But if it's not well set up, and a lot depends on the collaboration with our ED colleagues, so in places where there's good team effort and everyone is on the same page, it can go really quick. If there is sort of a buy-in issue or not much motivation to work together, it can be an hour and a half. So it's very dependent on local setup.
And the scanner's working all night then, presumably?
So that's dependent on location. So in the bigger centers, you have scanners operating all night. In the smaller centers, the technician comes in from home. But usually we would come in from home too, so there'll be a delay, but it doesn't take that long. The delays are not so much because of the things you would expect. It's more that people aren't just aren't getting a move on. It's more sort of complacency of the staff rather than the distance they have to travel. Do you follow what I'm saying?
This might be a simple answer, right, but could you potentially give me scanning for using the TIA result?
Yep.
If you're that
No. So that's a very good point, and that's been raised by some critics about thrombolysis. As I showed you earlier, TIAs that last more than an hour almost never resolve completely and will have some deficits afterwards. So it's very rare to get in before an hour, and most occur just around the 2-hour mark if we're lucky, and most occur around the 2.5 to 3-hour mark. So by then, if you're still having symptoms, highly unlikely you'll have full recovery on your own. It's possible, but it's just the longer you wait, the less likely. Also, if symptoms are rapidly improving, we generally will not treat. And then just one other new development is the dual antiplatelet. So if you get patients discharged from hospital, you might see them on aspirin plus clopidogrel. And that's a new thing. The CHANCE study was published was presented maybe 18 months now. It was a large Chinese study, 5,000 people, and they found that early antiplatelet treatments with the combination of aspirin plus clopidogrel improved the chances of not having a stroke recurrence in high-risk patients. So we do that for 3 weeks, and then we stop either the clopidogrel or the aspirin because long-term dual therapy has been associated with increased bleeding risk. So the reason why I want to mention that is if you see these people come, do not repeat their prescription. There's a reason why we've only prescribed it for 3 months. And so if you have
3 months or 3 weeks?
Sorry, 3 weeks. 3 weeks. 3 weeks. 3 weeks. So just 3 weeks. So if you stroke at this point in time, we have no evidence to support long-term dual antiplatelet with aspirin and clopidogrel in stroke patients. All right. I think I'm just going to press on with this.
Can you make a wee comment about global transient amnesia?
Yeah, so global transient amnesia is not usually ischemic, and usually we don't know what caused it. It's pretty unexciting in that regard.
Stress often does. I had a few, and always related to stress, it seems to be.
Yep, stress is some kind of a major sudden stress in life can trigger these. We don't know why that is. So you have generally an under 24-hour period where you don't lay down new memories and you don't remember what happened during that period. So you'll generally have lost all memory for that time frame. I've never seen that be a stroke. So we do see these with some frequency, probably 3 or 4 a year. We do CT scans on them. I've never seen that be a stroke. I have seen it be seizures. So I have diagnosed a few people who ended up having epilepsy, and these were partial, complex partial seizures that were just prolonged or non-convulsive status where they had several hours of seizing and don't have memory for it. The most dramatic case I've seen is this is probably 10 years ago now, a patient who'd gone on a skiing holiday with his family, and couldn't remember the entire holiday. It was a 2-week holiday, and we did an EEG, and he was having very focal temporal lobe seizures, and he just wasn't laying down new memories. And we treated that, and then he came right. So that can occur. It's pretty unusual. And transient global amnesia mostly is something where you provide reassurance. I always get an EEG ever since those experiences. And I've had another patient who then ended up having seizures. And I get the CT just for reassurance, but I've never actually found anything. Now, I do want to tell you about this thing. And you just indulge me for a minute. So this is my research, and I did a trial called the FASTEST trial, which was a multi-center cluster randomized controlled trial looking at an electronic decision support tool for GPs using a TIA tool to help triage patients, diagnose patients, and then offer opportunity to manage these patients in the community. And what this tool is, it provides diagnostic triage and management advice. The idea is that it's educational, so each time you do it, you learn more about TIA and stroke, and eventually may not need to use it at all. It links into the PMS, so it's a Bpac tool, so it links primarily into MedTech 32. It'll pull data, so those of you who've used Bpac tools, it's very similar to your other tools. It pulls data from your PMS and generates referrals, prescriptions, and information leaflets. And it gives, the way where we've set it up as part of the trial, gives the GP the opportunity to access direct CT and ultrasound within 48 hours if the tool supports this. And so we wanted to see how useful this was. The goal is to increase referral appropriateness, so most people still will be referred to the hospital, but to the right place. So we wanted to make sure that the people who go be admitted, or the people really needed to be admitted, and the people go to TIA clinic and maybe have a 5-day delay are appropriate for that, and those who didn't get admitted are the ones who didn't actually have TIAs. And we wanted to encourage GPs to start the treatments that are needed straight away, to not have any delays in therapy, and improve healthcare efficiency through better primary-secondary integration. So that's your MedTech toolbar, and you can install the icon up there. And then you have a 1-page data entry sheet that defaults to the most common types of presentation. And if you click things like right arm, leg, and right arm and face weakness and left leg, it'll say, wait a second, that doesn't make a lot of sense anatomically, so it sort of guides you through things a little bit. It then gives you a outcome page, so this is likely a TIA and the stroke risk is low. It says, you should refer to TIA clinic, don't forget to start the antiplatelet and the statin and the antihypertensive, talk to the patient about driving, mention the smoking thing, just sort of, it's like a little bit like tick box, you have to do that, have to do that, have to do that. And then it generates the referral. So if you click aspirin, it'll print out an aspirin prescription for you with the loading dose and then the daily dose to help make it a bit more efficient for you. It also prints an information leaflet for the patient that I've written, so it's not the whole guideline, it's just a 1-pager that we've had consumer input in. And the other option is you can manage them on your own. So you can click on that, and this is not live, but if you click on that, you see a bigger menu, and you tick off the individual things like the ECG. It talks about echo, when you might order an echo, Holter CT, and this walks you through that. It gives you advice on how to interpret carotid ultrasound if you get it back, what to do with it, when to refer to surgery. So this just shows you why the patient is low risk, so it explains the ABCD2 score, those things, and it gives you a reminder of what the driving restrictions are and why for different license classes. So the FASTEST trial was in 4 DHBs, Taranaki, Wanganui, Hawke's Bay, and Southern DHB, mostly the Otago end. So did anyone participate in this here? Okay, some of you know about this. So I just sent some letters out earlier this week with the outcomes to maybe not you, but maybe your colleagues. So we looked at 2 main outcomes, guideline adherence and stroke at 90 days, and guideline adherence was almost double in the group that had access to the tool. So this is just whether they used the tool or not. It was just available for you to use. 76 versus 41%, and stroke risk at 90 days was 1.2% in the intervention and 4.2% in the control group. That didn't quite reach statistical significance. But when we lumped, because we didn't have a lot of outcome events, we had fewer registration than we anticipated. If you lumped stroke and TIA recurrence, then that was statistically significant in favor of the intervention. Same with when we included MI and death. That also was significantly better in the intervention group. Other counseling was not great in either group. So this is your diet, exercise, smoking, and we all struggle with that, don't we? Because it takes time and we forget. So but it was still more than twice as good in the intervention group. And then cost was on average $1,500 less for the patients who were managed using the tool. And that was because more people were appropriately referred to ED who needed to be in ED, and the people who didn't need to be in ED were managed in the community. GPs generally liked the tool. So 55% of GPs said they would use it all the time if they had it available. 97% said they would use it most of the time. So there were times when they said, well, it wouldn't be that useful. They said things like allows quick evidence-based decision-making in a short consultation, no need to duplicate notes or letter, especially good for situations where diagnosis is unclear. So if you're not quite sure and the tool says, you know what, doesn't sound so much like a TIA, then you can show that to the patient, say, well, I don't think it is, and this doesn't say it's likely, so you have that reassurance. Specialists liked it, so they said that people had more appropriate medications on board, diagnosis was better, they got to us in a more expedient fashion. And then the other thing, so those of you who participated, you may have heard me talk already once. I offered pre-trial training in TIA and stroke. And those people the people who didn't attend the training nor had access to the tool, these are the outcome events, stroke, TIA and stroke, and vascular event or death. The people who had training only but not the tool benefited from the training. The people who had only the tool but no training did better than those who just had the training. And if you had access to the tool and the training, you had very few outcome events. So that's what we're promoting now, that the tool is launched, but that it's coupled with education like this today. And that's why I thought I'd take the opportunity to show this to you, so you've seen it, and it's got the TIA training, and it is now funded. Also one diagnostic accuracy, just to reassure you, we're not trying to replace GPs, and what we found was that this was the accuracy of control GPs, which is pretty normal internationally, about a 50% accuracy in getting the diagnosis right or deciding it's not a TIA after you've seen the patient. When the GP and the tool coincided in the diagnosis, when they both agreed on the same diagnosis, was the highest accuracy. People didn't just use the tool, they still used their own diagnostic impression, and that's really important in this. We've found in other studies that if you give it to non-doctors, it doesn't work. You know, it needs to be a doctor using it. I mean, there may be practice nurses, nurse practitioners, we didn't test that specifically, but people without a healthcare background, you know, beyond a medical student, doesn't work. So it's enhancing diagnostic decision making, not replacing it. So it's just come out on in Neurology last week on the internet as the results, and the ministry has funded it for national rollout, and we'll be pursuing that over the next few months.